Hello everyone, welcome to our webinar on falls prevention basics for people with MS. Your presenter today will be Emeritus Professor Sheila Lennon, and I'll be your facilitator, and my name is Peter Butler. In the spirit of reconciliation, MS Limited acknowledges the traditional custodians of the land we are meeting on today, and we pay our respects to their elders past, present and emerging. We also acknowledge our gratitude that we share this land today, our sorrow for the cost of that sharing, and our hope and belief that together we can shift to a place of equity, justice, and partnership. So just an introduction to Sheila. Sheila is the Foundation Chair of Physiotherapy at Flinders University in Adelaide. She's worked internationally in Canada, Switzerland, and the UK, and Australia, in a physiotherapy career that has spanned over 40 years. She retired as head of physiotherapy at Flinders Uni in January 2017. Her area of research and teaching expertise is neurological rehabilitation. Sheila is a fellow of the Chartered Society of Physiotherapy in the UK. She's the author of 60 peer-reviewed papers and 2 international textbooks on neurological physiotherapy and physical management of neurological conditions. Her current interests are balance and mobility training for all falls prevention for people with MS, with an emphasis on self-management and behavioural change. Sheila works clinically for the MS Society of SA and NT, offering falls prevention classes in both a face-to-face and Zoom format. So that's a pretty impressive intro. I will now pass you on to Sheila. So thank you very much, Sheila.
Yeah, thanks very much. Let's have the first slide. Hello, everybody. I'm very excited to share my experience of offering balance and mobility training for people with MS for falls prevention. And I have been working with closely with people with multiple sclerosis really since about 1986, when I was in charge of neuro rehab at Guy's Hospital. And in fact, at that time, I actually set up a joint exercise group for people with an MS between the acute neuro service and the community service. And the interesting thing about that was that we saw that the benefits were peer support, access to therapists, being able to main function, and encouraging people to continue with their exercises. So that really stimulated my interest in doing some more research related to MS. So if we just have the next slide. I want to start just by acknowledging all the patients and the health professionals and research colleagues that I've worked with in Northern Ireland and Australia. Now, what I would say to you is the exercise and the program I am going to concentrate on demonstrating a bit to you today is based on a series of research studies that I conducted with my Flinders University Master of Physiotherapy students. So I'm very grateful for their input into the initial development of the handouts and the program. But I'm not really going to talk about all the research studies that this program is based on, because I've already done another talk about that. I think it was in November 2020. And if you're interested, you can still access that recording for a small fee through APA. I really want to acknowledge the fantastic support that I've had for this program from the MS Society of South Australia and the Northern Territory, in particular the physio team led by Margot Strellan. If we could have the next slide. And I'm going to continue my PR just by letting you know that these are the 2 textbooks. And excitingly, we are just going to do the 5th edition, which will appear in 2023. And the reason I got involved with these textbooks, which were originally edited by Maria Stokes, was that I was getting very frustrated trying to teach undergraduate and pre-registration master's students the core material that they needed to get on top of in relation to neurological rehabilitation. So watch this space for those books coming out. Let's go on to the next slide, please, Peter. So you can see there's a lot of objectives on this slide, and basically I'm going to gear the talk into 3 sections. So I'm just going to very briefly give an overview of sort of important facts about MS, just because people have told me. We may have people of different health professionals here, different levels of expertise and experience with MS. So I just want to review the facts that I feel are important. Then we're going to have a section which is really going to look at falls prevention in particular, with a little bit of a research update. And then we're going to end the session looking at some of the key components based on some of the research I've done in my career, the key components of a falls prevention exercise. So we have a little bit of video clip for you, and then we're going to try and do a little bit of a practice or live demo of some of the exercises at the end. So just bear with us, because I'm not really used to using GoToWebinar, but Peter is very ably able to assist me on this occasion. Next slide, please. Okay, the main facts about MS, and I guess you can see the facts that you have on the slide there, but what I would say to you is that obviously it's progressive, it's unpredictable, it's variable, and basically it's the commonest cause of disability of young adults occurring in between 20 to 40 years. One thing I think that is very important to remember is that the last point about prognosis, that 10 years after onset, people with MS, 90% of people with MS are still walking. They may have some level of disability. So this is one of the really important aspects of our role, is to keep our clients encouraged and motivated, and encourage that they can do as much as they can to help themselves stay well and live well with MS. Next slide, please. So the interesting thing about MS is it can occur anywhere in the nervous system, because it's a myelin nerve conduction issue. And so, you know, the typical signs and symptoms are on that slide now. So it's very important, generally, when you start working with people with MS, to do quite a comprehensive assessment. So you can determine, according to the International Classification of Functioning, what the impairments are, the activity limitations, and the participation restrictions. Next slide, please. And basically that means that because every individual is different with MS, it's very important that any exercises that you do with the client, you try to individualize them to their needs. Now, what has changed really in the past 15 years or so with MS, which is very encouraging, is the advent of disease-modifying therapies. And there's so many medications available now, and that's not really my area of expertise. So I think the thing for us to remember with the medications is, when you're getting asked questions about the different medications, I listen to what the client has to say, and I usually make sure to refer them back to the MS Society, an MS specialist nurse, or the neurologist to address any specific questions. It's quite complex to decide which medication to go on. There's a lot of serious side effects. So it is a big decision for the clients to decide which medication is going to work best for them in collaboration with their healthcare team. But I think what this slide shows is definitely that what we know from the medication is, if you start early, if you get a better outcome. And basically what it's showing is the time to relapse is improved with the medication. Next slide, please. So that's a very exciting development. The other point I wanted to make was about exercise update, and these are the important points about the exercise. And as I say, in this session, I'm going to focus more on the falls prevention aspects. But the most important point is, when we look at a lot of the literature out there, and there's a wealth of literature now about exercise, the people in control groups either with MS either do not change or actually get worse in comparison to people with MS who exercise. So that's a big difference from when I qualified in all those years ago. in 1979. Exercise does not make people worse. It does not increase their relapse rate, but in fact, they really should be exercising, and they need to be exercising at the right intensity to improve their symptoms. Now, what I would say to you with people with MS is that probably what we're thinking about is more moderate intensity rather than high intensity. But of course, it really depends on the initial level of disability of your client. And I would encourage you to check out the training specific to people with MS for health professionals with Julie Davey with her MS Get a Head Start program, and you have that information on the slide. Next slide, please. Okay, so we're going to have a little poll now. So can you just write down for yourself 3 clinical problems specific to people with MS which makes them susceptible to falls? I'm just going to give you a few seconds to think about that. 3 clinical problems. I gave you a little hint in some of the preceding slides.
And just a reminder, if you could write those in the questions pane, that would be great. Thank you.
Thank you, Peter.
I've got a couple coming through here, Sheila. Would you like me to read them out?
Sure.
Okay. Lower limb weakness.
Yeah, good one.
Spasticity.
Yeah.
Fatigue. We've got a number of times. Weakness. Ataxia.
Okay, I think that's great, Peter. So we're going to go on to the next slide. And what I wanted to try and focus on with this poll, can you move forward to the next slide, Peter? I think if you want to focus on things that are really unique to people with MS, the first thing that springs, I mean, all those things that people have brought up are obviously very relevant. But I think what's very unique to MS is, first of all, it's the fact that it's a conduction block. You know, so that might mean they start off walking and they have no warning, and then all of a sudden, after a few meters, they develop drop foot. You know, that's quite different to a lot of other neurological disorders. And I wanted to just touch upon MS and fatigue. And the type of fatigue that people experience with MS is very particular to MS. And it's this overwhelming sense of tiredness, lack of energy, and feeling exhausted. So it's quite a complex type of fatigue, and the type of strategies we apply to manage it is to teach our clients good posture and good body mechanics, because that makes it less effortful for them to move, to control the temperature well, to teach them about energy conservation, prioritizing, and scheduling rest. So we work quite closely with the occupational therapist and nursing in relation to those points. Let's go on to the next slide. The other impairment that's very specific to people with MS is heat sensitivity. And this is something that you really need to be careful of if you're working in a group setting with these clients. When I run these classes, I usually do it in a group setting, usually by myself with up to 8 clients of mixed levels of disability. So I really rely on the clients to tell me if they are having any issues, but you do need to observe it. Now, the heat interferes with the transmission of the nerve signals, and that's already impaired. You can see that there's a high rate of heat sensitivity, 60 to 80% of people, and actually temporarily exacerbates their symptoms. So you might see someone in the class, for example, who starts to feel a little bit dizzy or doesn't feel too well, or is starting to get very flushed looking. And so you need to make sure that you cool down the environment, you know, use cooling products if you have them, and make them sure that they keep well hydrated for exercise. So that's an important distinction with people with MS. Let's have the next slide, please. So now we're going to be talking about just all the facts about falls and people with MS. And the interesting thing is, as I said to you, I've been sort of doing work in this area since about probably about 2010. And it all started with a large-scale RCT that I did for the public health department in Northern Ireland, which was an RCT that compared balance and mobility training for people with MS to people with MS in a control group. And really, the facts for MS are that they often have balance and mobility problems. We're all aware of that. They're frequently reported symptoms. As you can see in the second point, 93% of people are going to be experiencing walking difficulties after diagnosis. But more importantly, this poor balance and limited mobility lead to falls in this client group. Now, there's been a whole wealth of research since about 2013. People like Hilary Gunn, Jenny Freeman, Susan Coote in Ireland, and Jenny Freeman and Hilary Gunn in Plymouth in the UK, looking at falls frequency and prevalence in falls. Retrospective recall of falls is not really very reliable. You could probably relate to that yourself if you had to try and remember whether you'd had a fall over the past year or not. So really what we're aiming for to get better data with falls is prospective data. And you can see that the falls incidence increases up to between 50 and 70%. So people with MS fall a lot more than older people. Only a third of people over the age of 65 fall. And just think of all the time, resources put into managing that problem. And obviously in other neuro conditions, say Parkinson's, there's also a high prevalence of falls. I think even a bit higher than with people with MS. And just to put it a little bit in context for you, we know that there's 2.8 million people worldwide with multiple sclerosis, about 26,000 people living with MS in Australia. But if you compare that to Parkinson's, there's 10 million people living with Parkinson's worldwide, and between 85,000 to 212,000 people living with Parkinson's. So I think that helps explain a little bit why there seems to be maybe an explosion of research related to Parkinson's as well as multiple sclerosis. An interesting point in some of Susan Coote's work is that when she looked at 71% of people with MS, they fall in comparison to age-matched controls. So really, they fall frequently, and obviously they can experience quite serious injuries from these falls. So we want to do our best to actually prevent them. And fear of falling is a big issue in people with MS. And as you can see in the last point in the slide, that it leads to a loss of confidence in walking. They start to restrict their activities, and then they get into that whole downward spiral of immobility, deconditioning, and becoming more disabled. So my top tip in relation to falls is that walking is not enough. Walking is not the main falls prevention strategy for people with MS. We must really challenge their balance. So let's go on to the next slide. Okay, a little poll for you. So obviously when we're thinking about falls, we want to focus. There are many, many factors. I can't remember the exact number, but it's we cannot modify all risk factors, and I think the thing to remember is we cannot prevent all falls. We can do our best to minimize falls. So as Peter said before, if you want to put into the question pane, just write down 5 of the factors, the modifiable risk factors that you are familiar with to reduce falls risks in people with MS. And Peter, you can call out stuff to me if there's anything coming in.
Yep, we've got environmental factors.
Yeah.
We have footwear, appropriate gait aid.
Yes, walking is a big one, yeah.
We have fatigue management and conservation strategies.
Yeah.
And balance training, vision.
Okay, so we're not going to run through a whole list of all the impairments and signs and symptoms that can lead to falls, but we can do a lot about many of them. So let's just concentrate on a few things. Let's go on to the next slide. This is what's shown in the research by Susan Coote in Ireland and Hilary Gunn in Plymouth. These are the 4 factors that are modifiable and very influential in preventing falls. Cognitive dysfunction, and I'm sorry for that spelling error. I meant to change that today. I spotted it this afternoon. But definitely distraction and attention is a big factor for people with MS, and we can do a lot of things to improve that in falls management. The balance deficits, we can improve the balance, although we don't have very strong evidence in favor of improving balance specific to people with MS. We can change their gait pattern. We can improve the way they walk, which makes them less liable to fall. That we know we can do. We can improve walking speed, and we can teach them better use of a mobility aid. And I just can't tell you how many times I have people who maybe have had MS for over 25 years who come to this class and still are not using a walking aid or not using a walking aid appropriately. So that's something simple that we can target. We can definitely reduce sedentary behavior. We can improve strength. We can improve aerobic capacity. We can reduce fatigue. We have evidence for all those interventions. And I would say, we mentioned before that assessment of people with MS is really important. What I'm doing in my class is I'm running a group intervention. So I don't actually do individual client assessments before I start the class when I do them face-to-face, because when the clients come for the first class, and I'm going to talk about selection criteria in a minute, I get the clients to self-assess. That's all part of the self-management picture. So they have a little questionnaire to fill in so that they can tell me what they think their issues are in relation to why they're falling. And the sort of questions I have on that assessment sheet are things like, what is their falls history? Do they keep track of their falls? Are they able to analyze the reasons for their falls? Can they tell me why they fall? So really understanding the client's falls history is really a critical part of assessment for people with MS. Okay, let's go on to the next slide. So in terms of falls prevention tips and strategies, I think it's very important that the client understand how the MS systems are associated with falls. They're usually aware of their fatigue levels and heat sensitivity issues, but they might not be so aware of the fact that balance is dependent on vision, somatosensory input, and vestibular input, and they might not understand how manipulating those inputs may affect their falls risk. I usually need to explain to them as well about fear of falling, how it may have an impact on their physical activity and leading to social isolation. And that's the interesting thing. I do use a Falls Efficacy Scale International, which looks at fears of falling in my class, and that can yield some very interesting data for the client. And it's quite interesting because you might see someone who walks into the room to do the class, no walking aids, appears fairly confident, no really obvious gait impairments, but they might be scoring very high on their fear of falling. So there's a sort of an avoidance behavior that needs to be looked at, and the fear of falling behavior that needs to be looked at. People mentioned in the chat environmental risk factors, footwear and falls, and look, this is all important, and so we've learned a lot of lessons from the really rich literature that we have in relation to older people. But I find generally that people with MS are pretty clued up about the environmental risk factors and footwear, etc. That seems something that they've been able to take on board really well. But what they're not so good at is understanding their limits of stability and their falls risk. So it's important over the course of the 6 weeks that I work with the clients for 2 hours a week in a group of 8, that they start to understand their limits of stability and the risks they're taking. And and that they become aware of which activities are particularly hazardous for them. The most common ones you see in the literature are turning, bending, reaching, walking. So my top tips for falls prevention strategies, and you know, this is not rocket science, but actually these are points that you really need to make sure the client understands, is to be aware of their falls risk factors and to keep their hands free when they're moving about. The number one strategy that a lot of people that come to the class continue to apply is stop, scanning, and planning. So when they know that they're going into a riskier situation, maybe going outdoors or going into the garden, they take their time to scan the environment and plan the route which is going to be safest for them. The other point, they gain a lot of knowledge about why it's so important to keep physically active and challenging the balance. So they're really key strategies. We spend a lot of time reviewing their everyday activities, because what we want to happen is for them to start to integrate balance, challenge, and falls prevention into their everyday life as much as they can. And that in the literature is often referred to as incidental exercise, but be very powerful for encouraging clients to continue working on their balance when they stop coming to see you. And then on the other side of the screen, as we said, minimizing clutter, tripping hazards, that's all easy to sort out. And we just do a bog standard falls prevention checklist with them. Two other points: avoid rushing. That is something we need to talk a lot about in the class with examples from people in the group, and really knowing how to get on and off the floor safely. So we practice getting on and off the floor, and we even do that in the Zoom class. So the sort of strategies that I'm talking to you about today, I have the most experience delivering them in a group format, and I'm gaining experience since COVID in delivering it in a Zoom format, but definitely practicing and gaining confidence getting on off the floor is really critical. And it's surprising how many people have not been on the floor for ages, except when they've had a fall. So practicing that getting on and off the fall just gives them that confidence that they'll know what to do when they fall. And secondly, that they'll be able to guide someone else to help them to get up again. Next slide, please. We don't have a lot of time to talk about this because we only have like about an hour and 10 minutes, but there's some really exciting literature out there. And I'm more than happy to share the papers with you. If anybody wants to email me, I can point you in the direction in these papers. But there was a very nice Cochrane review, the first point, falls prevention specific to people with MS by Hayes in 2019. And you can see at that time there were only 13 studies involving 839 participants. And they did find small effects on balance, mobility, but they're not certain yet about the impact on falls. So we don't have the wealth of that evidence base that we do with the older people population, or even that we do with people with Parkinson's in relation to MS. A point that I wanted to make is to emphasize the reactive and volitional stepping interventions. There was a very interesting study by Okubo, that's the second point, in relation to older adults, where they looked at different ways of reacting instead of volitionally stepping, and they found that they reduced falls from 50%. So we can certainly learn a lot of lessons from the wealth of literature on older people that we can apply to the MS population. More recently, there's been a lot of interest in backward stepping. In particular, the reference by Monan and al. 2022. And they actually looked at the fact that to execute a quick and effective reactive step when you step backwards is vital to stop falls. So that's very, very interesting research. And there are other papers by Edwards et al. That showed that the 3-minute backward walking test is very sensitive to actually detect and predict people with MS who are fallers. So the backward walking test actually accurately classified 71% of people with MS who fell. And I guess on a logical side of things, as therapists, we know that practice walking backwards often exacerbates the deficits that we see with the clients. They can't rely on their vision as much when they're stepping backwards. They need to rely a bit more on their proprioceptive and their vestibular system. And the papers suggest that also it's a less of an automatic movement pattern when walking backwards, that you have to devote a degree of attention to it. And it's very functional to practice walking backwards because you have to step backwards to open a door, to sit on the bathroom, to etc. So there's a lot of reasons why backwards walking is something valuable to practice in class, and that's one of the stations that we do. There's also a lot of research out there now about perturbation training. Now, this is often done with a harness on a treadmill where they try and instigate slips and trips. And what they've shown in some of this research, and that paper by Mansfield et al. 2021 is really interesting, is they show that people with MS have delayed postural responses. So their balance responses do not kick in as readily as they should do in comparison to controls. And the last interesting bit of research that I wanted to draw to your attention is about the value of dual tasking. Now, I think one issue we have in people with MS is we can be very risk averse. And I think with good reason, because it's scary when people with MS fall. I think what we have to remember is a lot of people with MS fall frequently. Some of the people who come to my class are falling every week anyway, when they're not with me in class. And so we have to sort of weigh up the risk management with these clients. And I do actually push the clients quite hard and make them responsible for their own safety. And I'm going to talk to you a little bit more about the selection criteria later. But my question is, you know, in the past, we would have said to someone who was falling frequently, just concentrate on walking, don't talk while you're walking, etc. And in all honesty, I don't know the answer yet to whether or not we should be integrating dual tasking into falls prevention training. But I would say to you that the answer is probably yes, based on other populations. So I introduced dual tasking into some of the exercises in the class just to demonstrate to the clients how being distracted can affect their balance and their mobility. And by practicing it in class, we are seeing that they feel more confident. And they might improve their walking speed, for example, but there isn't a strong evidence base for that specific to people with MS as yet. Next slide, please. So how are we doing there, Peter? Have we got any questions?
We have had a couple come through. So the first question, what are your thoughts on AFOs as a modification for foot drop as a falls risk?
As a falls risk. Look, I think we need to use whatever devices help the person to walk better. I wouldn't see it as a falls risk. And certainly, it's better to give someone an AFO or to consider using a BINS or some sort of functional electrical stimulation to make people's walking safer. Any other questions?
Yes, just one more. What is the questionnaire you use to quantify fear of falling?
The FES International. That's a very standard questionnaire that's been used in many, many international studies. And if you're unfamiliar with it, if you want to email me, I can certainly point you in the right direction with it. Certainly many of the outcome measures, we'll just touch on those briefly, that are useful to use in people with MS are summed up in the Academy of Neuro-PT document, EDGE documents, which you can put into Google by the American Physical Therapy Association, and they will actually produce a huge document with all the outcome measures that you may consider applying in people with MS. Okay, so we're going to move on to the next slide now.
I've just had a couple more come through. Do you want to get to those a bit later, or?
Just tell me quickly what they're about.
Okay, just a question on what FES International stands for.
Yes, Falls Efficacy Scale International.
And what fatigue assessment do you use?
I don't do a specific fatigue assessment. There are many that we could consider, and I'm going to explain to you why a little bit later on in this talk.
Okay, a few more, but we'll move on.
We'll move on. If we don't get an answer to all the questions, Peter's saving the chat, and I'm sure we can try and email some answers to you. So I want to move in to talk more about the MS Falls Prevention Program that I run with the MS Society of South Australia and the Northern Territory. And if we go on to the next slide, please. Now, what I would say to you is that the results I've had with this program, they were about, you can see that I haven't done a recent analysis of this, and I'm sorry, I haven't had time to do that for this talk. But I've been offering these classes 2 or 3 times a year since April 2018. We offer them at 7 different locations across South Australia. I've also done training in this program in Darwin and Alice Springs. And when I look at the 88 participants, I think we had 61 people that I was able to analyze. It points to that I do a little evaluation of the classes every time I run classes for the MS Society, and what we are able to show that there's 71% compliance, so 71% of people complete the majority of classes 2 hours a week for 6 weeks, which is fantastic when you think of all the demands on people with MS time. And we've noticed changes in walking speed by 67%, improved 5 times sit to stand. These are little hints of the sort of outcome measures I use in my class. More balance, confidence, mobility, confidence using a visual analog scale, and a reduced number of falls. Very often people, in 63%, people are thrilled. They will say, I managed to stop myself from falling by taking a step. So they use step recovery. So we get that comment quite a lot. So I just wanted to give you a little bit of a feel for that. But I probably have data now since March 2020 on about another 100 people. So I want to really try and focus on getting that written up. Margot's heard that many times before, but I promise you, Margot, it's going to happen soon. So next slide, please. Now, before we go into the specifics of the problem of the falls prevention program, I just want to draw your attention to the fact that I feel very strongly that falls prevention is a complex intervention. And the sort of things that are important, which I'm hoping many of you agree with, are self-efficacy. We're going to talk a little bit about that tonight, but also mindset, the mindset of the therapist and the mindset of the client, and behavior change. So those 3 things are very important. I think that for example, I'm a physiotherapist, so I'm talking mainly from the physiotherapy perspective, and I'm not really talking about how you can use technology to assist with falls prevention. I'm just talking today about the simple strategies and exercises that your clients can learn to use to integrate into their everyday life. So I think we're all familiar with education. We do it in a group. The peer support factor is really important. The specificity of the exercises is important, and the postural control and the fact that you're challenging the balance is important. But what is really important are self-efficacy, mindset, and behavior change. And I feel that that influences the way we deliver therapy, and it is at least as important as the actual exercises that we practice. Next slide, please. So we're going to have just a very short clip of video, which I hope will illustrate for you, when you listen to Elaine, the importance of the therapist and the client mindset. If you could just play that, please, Peter.
I've had MS for 24 years, have struggled with my walking, but these classes have been fantastic. Sheila is a wonderful teacher, make us feel relaxed and excited about coming to the class actually each week. So I only came for 5 weeks. I wish I'd known the week before. My balance has improved, my walking. It makes coming to a class like this makes you aware of what you should be doing, not what you've been doing, and I would highly recommend it to anyone who gets a chance. Come along.
Thank you. Thanks very much, Peter. So mindset is something I've really been thinking a lot about as a therapist who's been working for 40 years. And very excitingly, we can find in the health psychology field some papers emerging. Yes, just leave that slide there for the minute. That's about behavior change, Peter. I don't have a specific slide on mindset. Thank you, Peter. And there is a whole lab set up at Stanford University of health psychologists. That's a reference by Crum and Carrie Leibovitz, who are investigating the power of placebo effects and actually acknowledging that mindset, if we define it as the patient's expectation of healing or recovery, this mindset is never isolated from social contexts. So the clients are influenced by the trust they have in the practitioner, which I think that's what Elaine was illustrating for me in her little spiel that she did about why she found the classes valuable. How their health professional listens and engages with them and informs them. So although if you look at studies, RCTs, where they really try and isolate the intervention that is under investigation, and they assign the rest of the effects to placebo, those placebo effects are actually really important. And I think one thing that's very important in physiotherapy is that we look at the combination of things that we do apart from the physical exercise and activity that are so powerful in helping our clients to improve. So I'm very excited by this research. And I'm going to be integrating that as a core principle of neuro rehab into the new book chapter that's coming out. So basically, our mindset influences our behavior, and that's the same for us, right? But it also affects adherence and our willingness to comply with exercise, which is very important. That's all I'm going to say about mindset, because we're rushing on through our hour. So if we can go on to the next slide now, I want to touch a little bit on behavior change. Susan Michie, the behavior change wheel, I've been following that work since 2011, and it's such an exciting piece of work. And I think it's something that we can all apply as therapists. And the COM-B model is looking at the capability of the client, the opportunity they have to improve, and their motivation. And that's what this simple model shows on the slide. So it's very important that you use this behavior change mindset when you're working with the client. So I think we're very comfortable looking at physical symptoms and safety It's a bit difficult to identify cognitive dysfunction in our clients with MS without doing more detailed psychological cognitive testing. But also the second aspect of the behavior change is the opportunity, and that's what a class will do, or working with your therapist on a one-on-one basis will do. It will give you the opportunity to practice the activities, the space and the time, and it all depends on the client's readiness to change. So some of you will be very familiar with motivational interviewing. That seems to be quite a common sort of training that health professionals use in Australia. Myself are much more interested in the COM-B model and also the promotion of self-efficacy, which I'm going to talk to you about in a minute. So let's go on to the next slide. So we don't really have time to go into this in any detail, but I just wanted to put those factors out there for you. So Fiona Jones and I used to work together in London many, many years ago, and she was the one who really introduced me to the power of self-efficacy and self-management. So self-management is, as we say, the maintenance of health and well-being, developing skills required to cope and change behaviors so the client can live the life that they want to lead. That's very important. But self-efficacy is their belief. So it's all down to the client's belief and their confidence to succeed based on the work of Bandura. And we know that self-efficacy is very important because beliefs make a difference in how people think, feel, and act. And we are the same. Therapist beliefs influence what we do in therapy. But we know also that if someone has low self-efficacy, it's associated with depression, helplessness, anxiety, and that we can promote and develop the skills of self-efficacy to develop confidence with the clients. Next slide, please. And I love this slide of Fiona's where the cat looks in the mirror and sees a lion. And really what it's illustrating is it's very much developing self-efficacy is about thinking about the goals, so collaborative goal setting, and the amount of effort that the client is going to invest in working with you and practicing the sort of exercises and activities that are important for them to practice. And it also refers to the concepts of things like resilience, which is also very important. And another concept that is coming out in the health literature is the concept of hope. And so these are all things that we can embed in our therapy practice to promote confidence and help clients adjust to coping. So let's have the next slide. We're just going to do another little poll. Just jot down 5 strategies that you feel clients can use to demonstrate good self-management. Now, I think in the interest of time, Peter, I'm very aware that I need to keep to time. So keep writing down your suggestions in the poll, but I would like to move to the next slide and give you some of the suggestions that I have for promoting self-management. And there's a whole pile of things there, but it's things like talking about concerns and aspirations. It's outlining treatment expectations and preferences. It's about goal setting. It's about exploring community resources, etc. So we're not going to go into this in any detail, but any neurotherapist, experienced therapist will have been used to using some of these strategies with their clients, but it's something I feel that we need training in, and I have done training in it. And I think if you can come across a good training program, some of you have done motivational interview, but others like the Bridges program, it's well worth pursuing that. Let's go to the next slide, please, which is now, this is a little clip of an education, an audio clip of an education session. Do you want to go ahead? If you could just listen to that, I hope it gives you a flavor that it's the emphasis on how we deliver the program that's important. Okay, so we've done, I think, 5 stations. So we're going to try for 2 more, is that correct? Done about 5? Because we started with Robbo there, 1, 2, 3, 4, 5. So that's pretty good. So we've already done a bit of exercise at the start, and you've already got through 5 stations, and I think we're going to get almost through 7 today. So that's really, really good. Does everybody have an idea of what's the main exercise that they need to work on for next week? Obviously, you want to run through the standing up, sitting, stepping, reaching, standing on one leg, etc. But is there a particular exercise that's really valuable for you? Who would like to start?
The clock.
Joe.
Me. And because that's relatively easy.
The
too.
clock.
Yeah.
Yeah. What is it about the clock that you need to work on the most, do you
Stepping
think?
backwards.
Backwards stepping. So you feel really off balance when you go back? Same with either leg?
Yeah.
Yeah,
Yeah.
okay, so that's good. So stepping backwards is good, but make sure you do it when you're safe. You've got a counter in front of you, or you're facing a wall with a chair behind, so that you can get the confidence to do that practice with the step.
Now with that, I'm just touching too, aren't I? So I'm
Yes.
not shifting my whole weight.
Yeah.
I'm just touching.
Yeah.
Yeah.
Just touch for now, and then eventually you'll be able to vary the steps and put more of the weight. Anybody else like to volunteer? Doreen.
Standing on one leg.
Standing on one leg. Is it equally difficult on both sides? Because there are different problems, or one side more difficult than the other?
Probably both the same, really.
Yeah, because it makes you work different things depending on which leg you're standing on. Yeah? What about you, Robbo? What do you need to work on?
Nothing phases me. Like, I'm prepared to try everything, but being on the ground or on the floor,
Yeah?
it scares me. That just say I was in the middle of the room here and there was nothing else.
Yeah.
Getting up.
Are you scared? Do you think if you can make your way to a chair?
Oh, I can get there.
Yeah.
But I do it all the time. If I crawl along, like I said to you, I groom the dog and I get a chair or something or the coffee
Yeah.
table I sit on. Then every now and then I go, oh, I get down my hands and knees, and then I got to go.
Yeah. So
somewhere.
you really want to try and be able to get off the floor without having to
Yeah.
go to a chair.
In case I'm in the middle of the backyard or
Okay.
something. And that's,
Okay.
but I don't, and I haven't even tried. I haven't done anything. I'm just too.
Yeah. No, don't try that yet.
No.
We're going to keep practicing that. And what else did you think you need to work on in terms of your walking?
Oh, it's that bending knee and working around that.
Yeah.
I noticed there when you said do this, when I go to the right, that knee, that automatically is that little bend, and when I come back,
Yeah.
that is stiff, and that is
Yeah.
just I got to work on, and that falls back into that one there and all. Is that knee being
Snapping
locked out.
back.
Yeah.
Yeah.
So I've got to
Yeah, so we got to really strengthen, that's what we call your inner raged quads muscle and also your hip extensor.
And
So
I haven't done anything in relation to that, and that's what last week when you said about not flicking it out and my walking improved straight away, you said.
yeah.
And so I thought, wow.
Okay, thanks very much. So I've sort of just cut that a little bit short, but I hope it gives you a little bit of a flavor of the importance of the education peer discussion element of the class. So we have a 2-hour class, which I'm going to talk to you a bit about, and it's a combination of education and exercise. And for me, both elements are really, really important. Okay, let's go to the next slide. Another thing that is a great opportunity for falls prevention or any time that you're working in therapy with your client is health promotion. And MS Research Australia came up with some interesting resources that you can access about health promotion. But what I always tell the clients is, yes, exercise and physical activity is important, but these other aspects, these other medications are important. So in MS, it's not just a question of taking your disease-modifying drugs. It's also a question that exercise is medicine. But if they concentrate on M is for mindfulness and mood, So we do a little bit of a practice using Insight Timer or Smiling Minds app about how to control breathing and to try and de-stress. The exercise physical activity is sort of obvious. We'll talk a bit more about that. But they need to also consider their diet and keeping hydrated. And S is for sleep and support. So getting the support and being social is also very important for living well with MS. And that fits in really easily to what we're doing in the class. Next slide, please. I think we're just going to move on, Peter. We'll just not have questions there because I'm aware that we're going to be running short on time. So let's go on to the next slide. Okay, let's talk about the key components of falls prevention for people with MS. And what this illustrates in my class of 8 people, that people can work at a series of stations as circuits. This is very useful when you have people of varying levels of disability. And as they get more used to the class, you can start to get more group interaction by getting 2 or 3 of them to work on some of the components as a group. So next slide, please. And these are the components that I work on. So the circuits, multi-directional walking, sit to stand, standing one leg, obstacle course, etc. that you can see. And then the topics for the education on the other side. Okay, next slide, please. And I'm very happy to share all of these resources with you if you want to email me. I have manuals for the client, manuals for the therapist. So please feel free to email me. Let's just show this last little video, please, Peter. 2 and a 3 and a 4. Careful, Jeff. Jeff, I think you're a little bit tired today. So I just thought I would show this little bit of video because it can be a bit scary working with 8 people and 1 therapist, especially when you see out of the corner of your eye that a person is putting themselves a little bit at risk. But Jeff, the person who stumbled a bit, is actually, I have confidence in his ability to understand his limits of stability. And what you saw in that video is, with the prompt, he immediately stopped and decided to take his walking aid to be safer. Okay, next slide, please. Okay, very importantly, I think we're using more, I use more a coaching approach rather than hands-on, although I do put hands-on when I'm working with someone at a circuit to give them a better feeling of what they need to practice. I think having neuro knowledge is not critical, but very helpful because you understand quality of movement, you understand compensations, you do very detailed analysis of movement, you understand the principles of exercise that promote neuroplasticity. But obviously you need to enjoy group work and I think be comfortable with self-management, self-efficacy concepts, and helping clients work towards aspirational and challenging goals rather than just realistic goals. I pretty much see as my job to help the client achieve the goals that they feel are valuable for them, even if I think they have no hope of achieving that goal. I would never say never. But I would actually work with the client to make them understand the steps required to achieve that goal. Next slide, please. So we do some screening by phone or email. So the MS Society screens clients by phone for me, able to stand 30 seconds and walk independently within a room with or without a walking aid. And then what I do in the very first class, I do a lot of observation, make notes as people are coming into the class, check how they follow instructions, see how they set themselves up safely, see if I feel confident that they understand their limits of stability. But they must be able, if you were in this class format, to perform the exercises without close by standby supervision. If they need close standby supervision, that they need to go for one-on-one therapy. So it's not a substitute for one-on-one therapy. Next slide, please. This is just a little suggestion of the measures that I use. So the FES, we mentioned 5 times sit to stand, a 10-meter walk. And it's really critical that I think we try and get our clients to speed up safely, because actually 1.14 meters per second is really critical to be able to cross 2 lanes of traffic. So to be an outdoor community ambulator, you want to be edging up towards 1 meter per second. And we want to see if we can get our clients walking more quickly, more safely. And there are lots of other tests you can use, but I think in the group situation, I have to balance out the amount of time that I have to actually deliver the program. So at the minute, I do 5 times sit to stand, 10-minute walk, 10-meter walk, visual analog scales, and the FES. I'd love to do the 4-square step and the 3-meter backward walk test because there's so much interesting literature about it. But I haven't had time to experiment with that as yet, as I say, because it's me versus 8 clients. Next slide, please. I put this slide up here because you will see that this slide reflects some of the measures that I take with them at the start of the class and at the end of the class. And I think it's very important that the client have this so that they can judge and track their progress for themselves. So that's something that we have in the exercise log, which is quite a useful tool for the clients. There's no point in me understanding what their outcome measures show. They need to understand that they're improving with the intervention that you're applying with them. Next slide, please. Just take about 30 seconds to shove some ideas into the chat, because progressing the exercise to continue to make it challenging is very important. So the balance boost exercises we use are standing, reaching, stepping, walking, sitting to standing, and standing on one leg. And we'll do a little demo of that at the end. But just write down your thoughts. And Peter, probably just go on to the next slide, because I really want to have time to do a little bit of demo of the class. So the sort of thoughts that are key for any of these activities is reducing upper limb support, of course, narrowing the base of support, getting them used to being on unstable surfaces. So we use a wobble board in the class, or they can work on a pillow. If they're doing it by Zoom or a foam pad, doing it with their eyes closed, incorporating reaching movements, step recovery, and dual tasking. So lots of ideas there. And what happens is I have these progressions written on an A4 laminated sheet, and I just put those 8 sheets up around the room I'm running the class in. So the clients have to read it, decide where they can start and how they can challenge more for themselves. Next slide, please. Now, as I said before, it's very important that the client understands the steps that they need to perform successfully to get back on their feet safely. So I actually go through this with the clients a little bit like I'm used to teaching my physiotherapy students, who really are a little bit limited with ideas about what are the essential steps towards walking safely. So we're just going to move on to the next slide. Don't worry about the poll. I don't want to rush too much. But here's a list of things that it's really important that the client understands. You know, quite often I've had conversations with clients. They said, well, when I work with my therapist, she's just always on about the core, how important the core activity is, and strengthening my core and strengthening my legs. And yes, of course, that is important. But you can also strengthen your core by performing functional activities. I'm sure we all know that. So I work through them and say, these are a list of things that you will need to be able to do safely to progress with your walking. So that gives them something to hang their expectations on. Okay, next slide, please. Okay, so I think we're catching up rightly there. I want to just show you a little bit, if I can. So I'm hoping you can see me. So this is how I set up the class when I'm doing a class by Zoom. So I make sure that the environment is safe. They have a chair they can hold on to when they're sideways. They have a chair behind them so they can sit down. They have a solid table that they can lean on to practice their exercises. So we do the balance boost exercises as a warm-up routine. It's a good way to get them used to understanding the critical exercises. So we practice each of these routines. So the balance boost routine for 5 minutes. Remember, we want to build up the intensity, and we make sure we have a 2-minute rest afterwards. So we just start and say, lift up one hand, the other hand, 2, 3, 4, 5, 6, good. Out to the side again, 2, 3, 4, 5, 6, mini squats, 2, 3, 4, 5, 6, stepping in different directions, forwards, sideways, backwards, switching legs, 1, 2, 5 times each movement, 3, 4, 5, switch out to the side, same thing, 5. Standing on one leg, very important to be able to stand for up to 30 seconds on one leg. Hold it there, feel the pressure through the foot. Try and stop that wobbling. Put your hands on your hips if you need to. Change sides. Hold. Keep holding. Keep holding. Change sides. Now back on the other leg again. Try and swing the leg. 1, 2, 3, 4, 5, and switch legs. Okay, that gives you a little bit of the balance boost exercise. Another circuit or exercise we practice are the balance boost responses. So we get the client to understand the ankle, the hip, and the stepping strategy. So the clients can be holding on either side. Getting the client close to a wall can be very useful in the class situation. If you feel the client is a little bit unstable, they can have a bench behind and a chair in front. I'm going to probably just go up on the toes, up on the heels, up on the toes, up on the heels. Again, 3, 4, 5, and practice the hip strategy. 2, 3, 4, 5. Okay, practice the sideways reach. Hold. Swing and hold. Swing and hold. Swing and hold. So about 5 times. Then step. Cross step. Cross step. Cross step about 5 times. Then step behind. Then step behind. Then step behind and stop. And the other thing I do with this class is I have my little, we're going to just stop there because we're going to need to wrap it up, but I use a little Bluetooth speaker and introduce some music into the class, but usually not until the second class because it's important that the first class is usually getting used to the exercises. And then the second class, you're getting a better idea of people's capabilities and what they're safe doing. So that's the right time to introduce exercises. Let's go on to the next slide, please, Peter. We'll just skip over that. We've been explaining that the demo. I've summarized on this slide what we do in the last session, emphasizing the key things that the client needs to take away with them to continue to practice to maintain their improvements in their balance. On the left are the 5 minutes that we do and the exercises we recommend, and on the other side of the screen with the white background is from the MSRA guidelines. Next slide, please. And I just wanted to end the talk with just a little bit of feedback from the clients. And I think what that illustrates is that if you look at the first slide, what the person has learned, he was a bushwalker who was falling, trying to get in and out of his tent, that how he became safe and minimized his fall risks, he started integrating standing breaks and using the stop scan plan. The second quote, for those of you who don't live in Adelaide, the walk is a 7.8 kilometer walk uphill, Waterfall Gully, up to Mount Lofty. It's quite a strenuous walk, and it took this client, she had the confidence to do it in 3 hours and 15 minutes. And as she said, she was surprised at the speed. Now, normally a keen hiker or runner might take something like an hour and a half to do that, or someone just walking at a fairly quick pace would take 2 hours. So it took her a long time, but she was really happy with her result. And the last thing is about the mental trigger to get back out there. And I think that illustrates the fact that confidence is such a key issue with what we're doing in therapy. So on that note, I'd like to see if we can have a few minutes for questions, if that's okay. If you could go to the next slide. Oh, does falls prevention need to be condition specific? Look, that's a really interesting question. For me, it does. It's more powerful, especially when you're doing a group class, because of the peer support and the tailoring of the condition, the education to the condition. And I tried to illustrate on this slide what's unique about people with MS. So it's not to say you cannot mix groups, because as you know, Kate Lorig's work, she was the first person to start doing chronic disease management classes, where she mixed people with orthopedic issues, arthritic issues, and stroke. But for me as a neurotherapist, I feel the clients get more out of it if they're working with people with the same conditions of themselves, because the peer support element is so strong. Next slide, please. And I just was summing up the main things there, and there's also some resources. Do we have time for a couple of questions, Peter?
Yeah, I think we can run through a couple of questions just before we finish. So I've just got a couple here that I'll ask, and sorry to anyone that if we don't get to your question, but we will endeavour to answer them over email. So just one here is it okay to give a knee brace to the client for knee buckling? The client has good strength, but still his knee buckles every now and then.
Look, I think anything you feel is going to help the client to feel safer and minimize risk is worth a try. I would never say never to any type of orthotic or walking aid. It's whatever works for the client.
And I've got a question here from Jane. How soon should a person diagnosed with MS be referred into a neurophysiotherapist? At time of diagnosis or at a presentation of a specific symptom?
Look, I think that a time of diagnosis is really the best time for people to be referred to the physiotherapist. The sooner we can get them referred to someone to explain to them what we can offer as a service to that client, the better.
And I think that might cover that. I'm sorry if I haven't got to your question because it's in between some of those poll answers, but I will. Yeah, someone's asked if we could collate all the questions and send answers to all the participants.
Yes.
We can certainly do that. and we can send those along with all the resources that have been shown here today. So do you want to talk on this slide quickly?
Look, you'll have the handouts, and just to reinforce with you that there's a lot of resources out there. The reason I started testing my program is I didn't feel that any of these resources delivered the full program that I wanted to deliver. There was always something missing from it, and I actually still feel that my program offers more than some of those programs that you can see there. But by all means, please feel free to contact me by email if you want any resources, any papers, any manuals, any laminated exercise sheets so you can run the class yourself. And also, I'm very happy if anybody would like to observe a Zoom class. I think observing a class is a very powerful way to understand how the class works. So if you're interested, email me and I will tell you the next time I'm running a class, and you can actually sit in one or two of the classes. So thank you very much for your attention. It's been lovely to speak to you. I tried to make this session as interactive as I could, but we're not so familiar with GoToWebinar as I am with Zoom, but actually I think we did a pretty good job, Peter.
No, I think we definitely did a great job, and I'll just apologise because it was originally scheduled for an hour and a half, but we had to cut it down to an hour. So thank you for fitting that in, Sheila. And I will just a slight correction here on this slide. It's got the MS Society in Australia. We're actually now known as MS Limited, and that's MS Limited's website there. But that's okay. And I'll just quickly go on to our services. We offer a number of services. So for anyone with MS or anyone with clients with MS, there are certainly a number of services there that you can utilize. And we also have a number of resources there as well, as podcasts and obviously webinars as well. And please, if you do need to contact us at MS Connect at ms.org.au or on the number on your screen there, and they will be able to help you. And just finally, a thank you to Sheila. That was a very informative and engaging session, and I'm sure you all got a lot out of it. And thank you to everyone who came along today. And just finally, before you leave, if you can stick around to complete a survey at the end, that would really help us a lot. Yeah, and have a good night, everyone, and thanks again, Sheila.
Thanks so much, Peter. Bye, everybody. Nice to speak to you.